Hi, welcome to You and Your Health. I'm your host, David Bertone. Today's show is going to be focused on low back pain, evidence versus fiction, and what's going on in the literature in terms of evidence to support some of the treatments and diagnoses as to what's going on in regards to low back pain. Before I introduce our guest, I wanted to throw out some statistics so you know what this is costing Americans and our society. Approximately 80% of all Americans at some point in their life will have an episode of low back pain. This is costing us approximately $86 billion per year, or about $6,000 every time a person has an episode of low back pain. It is the second leading cause of absenteeism from work, next to the common cold. So today we're going to find out some of the things that you can do to prevent low back pain, and more importantly, how do you treat it when it does occur. Our guest today is Jeff Snyder. Jeff is a licensed physical therapist, a board-certified orthopedic clinical specialist, and certified by the McKenzie Institute in Mechanical Diagnosis and Therapy. Jeff is also a principal owner at SOAR Physical Therapy in Seagirt, New Jersey. Jeff, thanks for joining us.
It's my pleasure to be here, Dave.
Tell us a little bit about your background and what you're currently doing, your practice.
Oh, Dave, I've been a physical therapist since 1981, so we're into 26-some years of being a physical therapist. My graduate training is in orthopedic biomechanics. I have a master's degree in that area, and I'm a PhD candidate as well. I'm also board certified by the American Board of Physical Therapy Specialties of the American Physical Therapy Association.
Great. We're going to talk today about low back pain and some of the myths. The first thing that's important is to talk about some of the sources of low back pain and what do we think is causing back pain, and to dispel some of the myths associated with that. Let's go through some of the things. A lot of people hear about their disc in their back, and how does that affect people with low back pain?
Well, disc injuries are a major contributor to back pain. One of the perhaps misconceptions is to think that the early stages of disc pain are caused by something else. Very often people have multiple episodes of back pain through a lifetime, and they are relatively easily resolved without treatment, any kind of intervention at all, and they're typically attributed to be muscle strains or something else. And the truth of the matter often is that they were never actually diagnosed, so we don't know. So one of the big issues is to recognize the contributors to back pain and the fact that there's a progression for most people in the stages of back pain, and that eventually lead to some level of chronicity if improperly treated.
Now, when most people have an episode, typically, they get better in a couple of days.
Exactly.
And then what happens is these episodes happen more frequently, and then they start looking for intervention. In terms of your approach, I know you look at it from a mechanical standpoint. What are some of the things that you do to help differentiate what might be causing the problem? And is it possible to do that, to try to figure out what's causing people low back pain?
Well, to identify exactly which tissue is at fault can be difficult. One of the most important things to do is to have some level of reliability, of course, to whatever level of conclusions you come to, and therefore what interventions you'll use. The advantage of a mechanical system of diagnosing back pain is that, first of all, since the bulk of back pain is of mechanical origin, it almost isn't too critical to be able to say this is caused by joint or muscle or ligament or any other specific tissue. And the examination process basically looks at repeated movements, positions, postures, things that influence the person's symptoms. So there's a good deal of discussion with the patient at the beginning of the examination process to identify what that pattern starts to become, and then it is confirmed with a repeated movement examination process.
So it's not necessarily just looking at special tests or x-rays or MRIs, where you're actually looking to see the movements of the patient and what's causing their problem, and then trying to use that to reduce their symptoms?
That's absolutely the focus. Now, it's not to say that those other tests and measures don't have a place. They do. But oftentimes there are false positives. Take the MRI, for example. It's very commonplace that people will come in, they may have already had an MRI, and the MRI shows that there is in fact a problem that doesn't become substantiated with the exam process. Well, so then you're left with the query about, well, which is it? And the reality is, as wonderful as the MRI is, and many other tests, there are false positives, and we have to be careful about that as the clinician, whether it's the physician or the physical therapist or any other practitioner, to make certain that we do have reliable signs and symptoms that are influenced by our examination process so that we can come to reliable conclusions.
You know, the research has shown that about 26% of people that have an MRI have some kind of a disc protrusion or herniation, don't even have back pain.
Absolutely.
So then they get that information from the physician, and they kind of hang their hat as the source of the problem.
Exactly.
And that causes some difficulty when you do your exam.
Right, because of course the danger would be that we would have an individual who has that false positive, but we see it in the radiological exam, and then we just make the mistake of treating it as that's the problem, and then we get poor results.
Okay. Now, let's talk a little bit about this disc herniation or protrusion. I know we have a slide that we're going to reference, and what's actually happening there when something happens with the disc?
Well, with all mechanical failure, and the human tissue, just like steel, wood, or any other material, it will fail with time. So it's not always a major assault to the tissue that causes the problem. Very often it's a slow process, a low-grade process. Take, for example, a poor postural situation or a perpetual bad lifting situation. And little by little over time, it stresses the tissues. In the disc situation, I'll speak in general about what we 90% of the time we have, which is a posterior protrusion of the disc, which is commonplace when people have a slouched posture. They're putting a lot of their body weight to the forward part of the disc, and that allows the disc to, over time, protrude to the rear of the person's spine. When that happens, they first start to protrude the disc out, and maybe the illustration would be helpful here. In the early slides, you'll start to see that the annular wall around the central disc is starting to protrude, or the disc is protruding into the annular wall, but the annular wall is not actually moving. That's an early version of the disc problem, and with more time and more repeated assaults, it starts to have posterior protrusion. When that happens, then you start putting pressure on different tissues. It might be onto ligamentous tissue. Eventually, it can be onto spinal nerve root tissue. It can go to spinal cord tissue, depending on the level of the disc. So the point is that with repeated assaults of forward pressure on the disc and further posterior migration of the disc, you'll get progressive damage of the disc. And that's how you get the repeated episodes, which tend to be a little more involved with each event.
Now, it's not the actual disc itself that's moving. That's correct, right? It's the center portion of the disc. It's like a jelly material.
That's very common. Anything could happen, of course, but yes, that's what is most typical, that it's the central nuclear material, which is jelly-like, as you said, and that tends to protrude through the annular wall.
And that'll put some pressure, may put some pressure on nerves in the area and other tissue, which may cause pain, not particularly in your area, but in other areas.
Right, what we would call referred pain, so that if that tissue, be it nerve tissue or ligamentous tissue, has shared innervation to another part of the body, then you'll feel that in that area as well. So it could be central pain to start, it could be one-sided pain as it progresses. With even more progression, it can travel down the leg in the circumstance of the very low back disc issues.
Well, we'll get into that a little bit later on. Let's talk about some of the red flags or some of the other things that we worry about as physical therapists that may need referral to a physician. Obviously, people can see us immediately without seeing a physician to be treated for back pain, and then we'll do our exam. And if we see certain things, what are some of those red flags that you need to be concerned about?
Well, some of the real big items is how did this start out? And if there's a traumatic event where a person needs to have a radiological exam to rule out things like fractures, for example, it would be inappropriate to see the physical therapist first, and we would always, if they in fact made it to our office as the primary caregiver, we would refer them to the physician first. Additionally, pain that is constant and doesn't change for any rhyme or reason, pain that's present at night as well, pain that's present when the person is in an unloaded position, lying down, for example, and again, does not change. Those are serious red flags. Additionally, there are, if you have bowel control problems, bladder control problems, if you have weakness in the lower extremity or in the upper extremity when it's a problem further up to the neck level, these are red flags.
Okay, and they should see the physician immediately in that regard. Let's talk about the common causes of low back pain in terms of the posture versus dysfunctions that we see and the term derangement. How do these all three things help people understand a little bit better about what's actually causing low back pain?
Right. Certainly there are lots of causes to low back pain, and the primary concern here is that because it's in epidemic proportions in terms of the number of people involved and costs, we have to start thinking a little bit realistically about what's common. And by far the most common causes of back pain will fall into three different categories, at least as described by the McKenzie Institute in Mechanical Diagnosis and Treatment. The first is the derangement syndrome that we've been talking about. And it's not necessarily the disc that's the problem. It is likely the disc, it is often the disc, but anything that is a mechanical blockage that can move within that space can fall into that syndrome of derangement. And there's different classifications of derangement that become apparent to the provider when they're doing the repeated movement exam process. That's the most extreme. The other extreme is the postural syndrome, where the individual basically assumes certain postures for prolonged periods of time, and there's a lengthening of the tissue, the ligaments and the other motion-limiting tissues, and the person just has pain from the stagnation and the constant load on those tissues. Very easy to fix. One or two visits for just a correctional kind of a thing. Well, first I should say, before correction, confirming that's what the problem is, and then teaching the person what to do about it. The second area, in the middle of those two extremes, is the dysfunction syndrome. And essentially that typically has an etiology or a cause of having started because of a postural syndrome that was not well addressed. The person, after many years of functioning in bad postures, has adaptive shortening of tissues, and so when they start to lengthen those tissues, they then hurt. No different than if you had a cast on because you had a fractured leg. You take the cast off the knee, for example, you try to bend the knee, and of course it hurts. Our instinct is to say, don't bend that because it hurts. But with the knee example, we commonly understand, well, I've got to restore the motion to get normal function. And sometimes that doesn't translate into how we should approach the back. Sometimes the right thing to do is replicate the pain, though you should not be any worse for having done it, meaning that you would feel the pain of stretch when you go ahead and do an exercise to correct the tightness. And it goes away when you stop. And by repeatedly doing that, you'll restore the mobility just as you would in the knee analogy.
Some of the things that I tell my patients is that, they're always looking for that one cause of the pain. Well, I picked up something and I hurt my back. And I need to always educate them that may have set it off, but that usually is not the cause. It's been developing over years. And that's what you mean by these postural syndromes and these dysfunctions, right?
Exactly.
So it's a cumulative effect.
Exactly. So we can't focus on the straw that broke the camel's back. We should be thinking about the years of history.
And we'll talk later on about the prevention and how do you handle some of these things. But I think it's important now for people to understand that there is these different areas that may be causing the pain, and you need to start addressing those and treating them appropriately, and the mechanical approach may be the way to do that.
Absolutely. And it's certainly a very conservative approach, and we'll give you some quick answers, and you'll find out in a short number of visits whether or not this is going to make a difference for you.
Okay, so after the break, we're going to come back and talk about some of the interventions that can be done to treat the pain itself, and then how to prevent it, and review some of the misconceptions about low back pain, what the public may think is helpful for them and really isn't.
I joined the National Guard and never thought I'd be saving lives.
I put on the uniform and I have a whole new outlook on life.
Country, community, family. That's what matters most to me.
that matters to you, go to 1-800-GO-GUARD.com.
Welcome back to You and Your Health. I'm your host, David Bertone. Our guest today is Jeff Snyder, a licensed physical therapist and a specialist of treatment of the spine. We're talking about the mechanical approach to the treatment of low back pain. Jeff, again, welcome to the show.
Thank you, Dave.
So we talked a little bit about some of the possible causes of back pain and how it's very hard to determine what tissue is involved. Let's talk right off the bat about some of the misconceptions that people may have. The term slip disc is widely used in the public. What is actually happening with the disc material, and why may it be a source of pain?
Okay. Dave, as I spoke earlier about the derangement syndrome, the person could have a movement of their disc and it could go in any direction. And I spoke most of the most typical scenario of a posterior protrusion. It can move laterally, it can move forward just as well. But if you look at this spine model here, you'll see that the disc between each pair of vertebrae, it can have movement. When it moves in the posterior direction, it can place pressure on ligaments as well as the nerve. When it moves into the anterior direction or the lateral directions, it can put pressure on other soft tissues, ligaments being one of the major.
Now, is it the actual disc itself, or it's the center part of the disc?
It's not typically the disc itself.
Okay.
As I said earlier, that annular ring typically stays in place, and it's the nuclear central material that moves out.
Pushes out to the wall and puts pressure on one of the tissues.
Yes.
Okay. So nothing's actually slipping out of place.
Correct.
Okay.
There's a migration of the inner tissue.
All right. Some of the other terms, sciatica. And what is sciatica?
Well, sciatica is a term that's specific to the sciatic nerve. The sciatic nerve is a major nerve in the posterior part of the leg and innervates the lower leg and other muscles on the way down. But the point is that when you have pressure or some other mechanical entrapment onto the sciatic nerve, it will create symptoms, be they abnormal sensations or weaknesses of the nerve.
So when people say, I have sciatica, most commonly it has to be in the back of the leg, correct?
Right. And the error is to use the term sciatica to refer to multiple nerves having this kind of a problem.
So if they have pain in the front of their leg or in the front of their lower leg, it really isn't true sciatica because it's not the sciatic nerve. It's referred pain, or what we call radiculopathy.
Right. The sciatica is a subset of any radiculopathy. Radiculopathy is a general term that refers to pain on any of the nerve tissue. And so depending upon the area served by that nerve tissue, you will have symptoms in that area.
Okay. Muscle injury. How rare is it to actually injure the muscle in your low back?
Of course, anything's possible, but the muscle cause to back pain is much more rare than people realize, which is not to have the misconception of thinking that when we approach a core training approach, for example, to the muscles, the motor control, the motor learning, the developing strength of the deepest core muscles of the spine is critical to holding good postures, but it's not usually the muscle that's the injured source as much as the muscle is not doing a good job of controlling the positions and postures that lead to those other three syndromes.
So the misconception is somebody bends over incorrectly, picks up a heavy box, they think they strain the muscle in their low back. Is that really occurring?
It's possible, but rarely the case.
Very rare.
And when we go to the repeated movement exam, we're able to eradicate pain in minutes many times, and therefore we need to ask ourselves the question, did we therefore resolve the muscle pain? And we therefore, in confirmation of the exam process, need to restore the pain and take it away again, looking for repeatability. Do I in fact know that what I think is the source of the pain is in fact the source of the pain? But the point is, we cannot turn muscle injury on, off, on, off. Mm-hmm. And that's one of the ways that we exclude that as the generator of pain.
Okay. Some of the other terms, it's people get glossy postcards and other advertisements about the term subluxation. Is there any evidence that really supports this term, and what can you say about that?
Well, in its basic form, the term subluxation, movement of the discs, or not the discs, I mean the joint surfaces, so they're not in approximation with each other. Does that happen? Sure. Is that the cause of the pain is probably the stronger question. And by manipulating that, is that going to resolve the problem? We, as physical therapists with mechanical diagnosis and therapy approach to our care, we don't ever treat subluxation, and we have excellent results. So that makes me question whether that is an appropriate diagnosis and approach to resolving the pain. In the dysfunction syndrome, there are people who have limited mobility in the joint segments, and those people respond well when we manipulate those joints to restore the mobility of the capsule surrounding the joint. But no, I'm not an advocate of the subluxation theory as a cause to back pain and manipulating it as the proper approach to resolving it.
Or it's not really necessary to manipulate it over and over again.
Not over and over again, and certainly if, for example, I'll have a patient come into the office and they'll say, well, I've been having my subluxations treated for the last several years, and the first question I'll ask is, well, if it hasn't resolved in year 1 and it hasn't resolved in year 2 and year 5 and so on and so forth, are we doing a good job as practitioners in managing your problem? Shouldn't we be focused on a higher goal, which would be to resolve it and teach you how to maintain the resolution?
I think the education is very important there. We also have a slide about degenerative disc disease. Can you talk a little bit about that, and the influence of that on people with back pain?
On the slide, you'll notice that in the areas where there's the most disc degeneration, you'll see a narrowing of the joint space. So the vertebrae on the illustration are approximating each other. One of the levels on the illustration has a very narrow disc. One of the problems with that is that we're not able to shock absorb and dissipate the loading effects of body weight any longer when that happens. Additionally, you'll see on that same slide that there are osteophytes forming at different areas of the vertebrae, and that can cause pressure onto ligaments, causing pain. There's also a narrowing of the spinal nerve root canal called the foramen, and that brings about another source of pain because now we can have encroachment onto the nerve. So the degenerative disc process, it's not good to refer to it so much as a specific diagnosis as much as it's a process that increases likelihoods of the radiculopathies we spoke of earlier and pain in the extremities depending upon the level of the involvement.
I think it's important for people to understand is that the best approach for that is to prevent that, and that's through exercise and nutrition and maintaining your spinal health.
Exactly. And again, going to that same illustration, you'll notice that there's a reduction of what we call the lumbar curvature. The normal inward-backward curve of the lumbar spine is the best position for the spine to be in order to dissipate forces through the spine. That degenerative disc scenario has a reduction of the lumbar curve, and again, we're impaired in our ability to shock absorb.
The last misconception, the use of back supports. Can you talk a little bit about that and educate the public about that?
Well, let me put it this way. Back supports control motion, and if motion control is the primary goal, then it could be an appropriate approach. However, the majority of people that we see with a mechanical diagnosis approach are people that need to resolve lost motion, and we need to teach them how to correct their motion. If they're in the derangement syndrome, we need to have them do repeated movements to help push the disc back into its appropriate place or whatever the other derangement structure is. If they're dysfunction people, they have adaptive shortening because they haven't been moving to the extremes of movement. So again, we need to lengthen the tissues to restore that movement. If they're in the posture syndrome, then there are people who don't have good motor control, and we need to teach them that control. So by bracing it, we're interfering with that learning process of controlling posture.
And how about the misconception that somebody will put a tight belt on or weightlifting belt, they're going to go lift something? We know that it's important to use their body mechanics more correctly than it is to put that belt on.
Exactly.
Right?
I mean, if anything, I'm more inclined to say, to educate the person and let them know that if you feel your symptoms coming about, something is wrong with your motor control. Maybe you haven't found the right muscle that needs to control this motion. Maybe you're lifting too much weight for what strength you have in your trunk muscles. So often our focus is on lifting greater and greater amounts of weight with whether it be a leg lift or a shoulder lift or whatever the motion is. And we have to stay focused on the core training of the spine, and the spine needs to keep those postural controls no matter what the arms or legs are doing. And so if we use the onset of the pain as a feedback tool and say, wait, let me rethink what I'm doing and correct my postures as I'm doing this activity, often you can then control the pain by correcting the problem. And using the brace is a tool which helps you overlook the proper correction.
Let's talk about the treatment and the self-treatment approach for mechanical low back pain. What should people do, the average person do, in terms of they wake up, they have back pain one morning, or they play a sport and their back aches, or what are some of the things that people should do?
Well, the first thing to do is try to observe if there's a pattern to their symptoms. And the physician, the physical therapist, whoever's examining that person, they should be asking the right questions to help them identify what that pattern is. But certainly, if being clear about, is there movement that's going to aggravate the pain? Is there different motions that are going to aggravate the pain? These are things that need to be reported to the practitioner so that they can help decipher what the problem is.
How about the old adage, should I use ice or heat, or if something aches, what should I do in that regard? If I clearly have back pain and it's the first day, what do you recommend that the person does, the lay person, before they see a practitioner?
If they end up having a situation where they cannot influence their pain themselves by just unloading it, lying down, things of that nature, and it may be the case that they do have some inflammation to the area, certainly icing the area is the best approach whenever someone has inflammation. And any active inflammation, acute inflammation, which is a few days old, 3 days or less, ice is the best approach to that. I guess I just want to caution on the issue about what should we think in terms of apply the ice immediately, because ice will reduce your perception of pain, and if you have one of these other mechanical causes of pain, it might not be the right approach.
Well, what about some of the things that don't work? Quickly, we know that people are on bed rest too long. What's the misconception about that?
Bed rest, of course, might have here's what's valuable about the bed rest. Let me put it this way. Unloading the disc. So if you have a derangement that's of disc causation and it's a severe case of it, you might need to unload it. But to just go straight to bed rest and go to a position which is the least painful often is the wrong solution. I'll try to make a quick example. If a person lies down on their back and puts pillows under their knees, as is often the case, and if they are one of those 90% of the people with who have a derangement and it's a posterior derangement, that's going to feed the problem, in that with that knee position, the person is in a flexed position, the disc will protrude further to the rear. They'll feel less pain because they're opening up the space to the rear, but the position of all of the structures allows for more posterior migration. And they'll have a great deal of difficulty often changing position, getting out of the bed.
So we want those people to walk and move a little bit if it doesn't irritate their pain. Is that correct?
That would be the case in that situation, yeah. But again, the biggest issue is if you've identified the problem with a good mechanical diagnosis, then you'll be able to be told in day one, these are the things you should do, these are the things you should not do. And again, the patient education component is enormous.
Great. Well, Jeff, thanks for joining us. We really appreciate it.
My pleasure, Dave.
You've heard today about low back pain and the mechanical approach, the evidence to support it, and how you can use it, and using the expertise of a physical therapist to treat the problems that you may be having and help prevent and treat your low back pain in the future.